And good afternoon, everyone. And I think that today I'm very interested in the topic, the rise of intravascular imaging, and we can get some new thing from the guideline 2024. So I think that maybe I speak in English or Chinese. English, okay? Okay.
Up to you.
Okay, and I will mention a combination of about the Chinese doctor and foreign doctor together. We don't know speak in Chinese or English, but I can speak in English. And we all know that intravascular imaging, we all think that is very important in the guideline of PCI. But before 2023, and the guideline recommendation about intravascular imaging is about up to class 2A. And we know that for imaging for the PCI guidance, get the stent optimization recommended class 2A, and for unprotected left main PCI, I was recommended for 2A. And for stent restenosis equals to IROS and OCT to class 2A. But just before 2023, just up to class 2. But something changed from 2023, and we get two new guidelines from EIC conference. And the first is the acute coronary syndrome guideline management, and the second is the CCS management guideline 2024. They equally and give some rise, status rise of the intravascular imaging. Let's first pay attention to EIC guideline 2023, and we know the management of acute coronary syndrome. And just before, and we know that if you not very clear calculations, you can use intravascular imaging. But now from the new guideline, if the calculations is clear, you also need to use intravascular imaging, IROS or OCT equally, and to get a good stent implantation optimization. But if calculation is not very clear, you must use the intravascular imaging to detect what type of the calculation is plaque rupture, plaque erosion, or calcified nodule, or some other such like SCAD. And so you depended on the imaging examinations, you determine the treatment strategy to use the stent implantation medication or DCB or something else. And so this is recommended 2A, but OCT is better, is 2B recommendation. And something new in EIC guideline 2024. And we know that, and just last professor has said CCIS guideline. But in this guideline, we get the intravascular imaging recommendation is that's equally for IROS and OCT is recommended when performing PCI on complex PCI, such as left main, true bifurcation, and the long lesions. But you know that now the recommendation class is 1, and the level is A. And so something very new for intravascular imaging in complex PCI. If you do left main true bifurcation and the long lesions, you should use intravascular imaging, and IROS and OCT are equally. And so a great change promotion of the status in intravascular imaging is based on the data support imaging benefit, such like the Lancet network and Illumin 4 October complex and OCT IROS studies. And now let's first go to the network meta-analysis about Lancet network meta-analysis design. This design is just compared, including 22 RCT studies and across three imaging modality, OCT, IROS, and angio-guided. And so we can know the primary endpoint is touch lesion failure. And so by intravascular imaging guidance, we can guide 25% reduction in all-cause mortality and 45% reduction in cardiac death and 17% reduction in myocardial infarction and 48% reduction in stent thrombosis. And compared with complex PCI, renovate complex PCI, we know that for total target lesion failure and in meta-analysis is 29%, but in complex PCI study is 37% the decrease, and so we see the similar decrease of the miss decretion by imaging guidance, and so all told us that by complex PCI we should use intravascular imaging guidance, and we also I was also asked by one question: OCT is better or IRIS is better? But in this meta analysis, we know that OCT guidance is similar with the IRIS get the decrease of the TLF, cardiac death, and stent thrombosis. And the second study is Elimin-4. Elimin-4 is focused on complex patients, such as in clinic, high-risk patients, diabetes mellitus, and high-risk lesions, such as non-STEMI, STEMI, and long multi-lesions, diffuse or multifocal incident restenosis, CTO bifurcation. And so this is clinical difficult patients and difficult anatomy, and for OCT guidance and angio guidance comparison. And we know that by OCT guided PCI lead to superior final post minimal stent area is larger than angio guidance. But for clinical miss and so for safety benefit, OCT guidance is even better, and so the stent thrombosis is very low. But clinical result and for TVF and no significant difference between OCT guidance and angio guidance. But we know that pay attention to the data and just before COVID-19 and get a very good result. But after COVID-19, it just a similar result, and so it should possibly impacted by COVID-19 pandemic. And the third study is the October study. October study is designed to focus to bifurcation lesions, such as left main bifurcation or non-left main bifurcation. And the left main bifurcation including 26% of the patient. And for the design, and we should use bifurcation PCI should use OCT 3 times. The first is before stenting, and so we should do OCT examination to find what's the feature of the lesion and what kind of preparation for the lesions. And the second is after the main vessel stenting, after repair into the such as the circle or diagonal, and we should use OCT examination again to which cell you into the side branch. It should be the distal cell, and then after the casing balloon, use OCT again to make sure about the good stent expansion and position of the stent get the good result. And so we can see by very strict OCT guidance and the true bifurcation, and OCT guidance can cause the decrease of the all-cause mortality, cardiac death, and target lesion, myocardial infarction, and get a significant difference. And you can see that 30% of patients they don't have the miss compared with the angio-guided true bifurcation PCI. And you just think that it just also impacted by COVID-19, and before COVID-19 have the even better result. And so for renovate complex study, and this study is just OCT hours guidance compared with angio guidance alone. But in this study included complex lesions such as incident restenosis and calcification, true bifurcation, CTO, unprotected left main disease, and long lesions, and the also coronary lesions, and this is the true complex PCI in clinic. And so we can see that compared with angio-guided, OCT hours guided PCI get a very good result and lower than the target vessel failure compared with angio-guided. And OCT hours study is very interesting. This study is just designed to two arms. The first arm is OCT guided PCI. The second is hours guided PCI, and use the primary endpoint is TVF, and to compare these two intravascular imaging modality, and we get the similar result of the two imaging modality. This told us that OCT is similar with the hours guidance, and you can even see that the right line is OCT guided is lower than the hours guided. It had a trend but the lower miss ratio. And the last study is Occupy study, and Occupy study is designed for complex PCI, for OCT guided and angio guided, and you can see that the inclusion patients about acute coronary myocardial infarction, CTO, long lesion, calcification, true bifurcation, unprotected left main, small vessel, and stent thrombosis, and restenosis, and cabbage bridge lesions. And for OCT guided, get a good result for the lower miss ratio. This is, and the thing like the best thing the patient can be benefit is from spontaneous myocardial infarction and TVR. So this is the subgroup. If you have the stent optimization, get the good the minimal stent area and expansion position, and without dissection of the stent edge, and you can see like very low ratio of the miss. And so they told us if you use the intravascular imaging to get complex PCI, you should get a better result and optimization. And so this is the reason why the CIC guideline and recommended intravascular imaging in complex PCI such as left main bifurcation and the long lesions about recommended class 1 and class 1A, and based on just so much intravascular imaging studies such as the meta-analysis and Occupy, Illumine for October, OCT hours and doctors, and so on. And so one take-home message, I think that maybe some doctors, they still have the idea, I can do PCI, complex PCI only by angio guided. But you know that now the guideline suggested you strongly use the intravascular imaging modality in routine complex PCI. And the routine use of intravascular imaging has shown to improve clinical outcome, and imaging guided PCI show the procedure and clinical benefits, including safety benefits. And so now growing evidence for intravascular imaging already lead to stronger recommendation in 2024 EIC guidelines on CCS. That's all. Thank you so much.